Hi, welcome to SDSF Live. Let us know where you're logging on from. I'm Nicole Shin from Houston, Texas. This show is brought to you from the Shwachman-Diamond Syndrome Foundation, providing support for patients and their families around the world. As a reminder, this show is public. Please do not post any private questions. These shows are uploaded to SDSF website and YouTube. Subtitles are added, and you could use the translation tool after it's uploaded. We're still working on converting these to podcasts. I've been on the struggle bus with my audio. I'm going to try for my phone today. So hopefully we could get that kink worked out and make that happen for y'all. We have a fun giveaway today. Michelle, we missed you last week. How are you today?
We're doing okay. We're on a lot of struggle buses over here. I don't really know where. So I am happy to be back with everybody, and I missed everybody very, very much. And so this makes my heart happy.
We have a double header show tonight. It's a twofer. You could win this plush liver by interacting with the show in any way. Like, comment, share, start a watch party.
I think these are so cute. We have a couple of them, and we use them a lot in our discussions with our children about SDS and all the different aspects of it. We've got a neutrophil floating around. I think we've got a stomach, and they're just really
we have
cute.
A bunch of these too. It's from I Heart Guts. It's a really great website. They actually have like erasers, they have plushies, they have lots of fun stuff, stickers, lots of fun stuff.
Definitely some good tools in case. I even I was going to look into if we ever did start public, if we sending erasers with neutrophils or something that would help explain what's going on a little bit. So
fun.
Yeah, I like them. Looks like we have someone here from Denmark already. That's so cool. I love that. Cool. There's so many different. I feel like we need we need one of those pin boards.
A map. We need a virtual map that pins like everywhere in the world.
I'll make a graphic for that.
As a reminder, we just passed our 1-year anniversary.
We did.
Michelle and I are both board members for SDSF. We're moms, SDS moms. And Michelle had the idea to do a Facebook Live just to explain SDS one time. And the next day I was like, we should make this a show. And I booked 40 guests or something like that. So we just passed our 1-year anniversary. We're trying to figure things out as we go, but I think we're doing a pretty good job considering.
I think we're doing phenomenal considering all of it. Oh, yeah.
We're not techie people. We're not professionals at this.
My favorite thing is to actually look back and see some of our first shows, and I'm like, it's like cringing on the inside, but I know I remember like you and I, we've gone through the struggle bus on them. We've tested audio. We looked into programs. We did, everything was, and so it's just like this, like, it's almost like, one of those little baby books that you open up after 9 months and you're like, oh, look how far along we were. Like, look at the time. And it was
big time.
It worked really well. I think it's great. I like it. I'm glad you signed me up to do more than one show. That brings me joy.
We have our first poll question.
So there it is. So do you or your child suffer with I have no words. Struggle with successful nutrition? And I think this can go for just about anybody, SDS or not. I think there's always some type of a challenge with nutrition, whether it's more in the SDS realm where it might have to do with the pancreas or motility or fat absorption, things like that. But we ask these poll questions because we always like to get a feel for what the audience needs. We want to know how best to help you guys, and this kind of gives us a little bit of feedback, so we know where to go, or maybe who to have on the show, or what questions to ask, things like that.
Exactly. If you're new to SDS, this is another great show to watch. Tonight we're continuing our camp series and piggybacking on our show with GI Dr. Grover last week. We have Katherine Truscott, a dietitian from Boston Children's, as well as Dr. Wehrman, a hepatologist or liver doctor for those of you who aren't familiar yet, from Boston Children's. They both work with Dr. Grover. I just noticed I have a glow in the dark tattoo. My kids have tatted me up. So if you see that, it's a glow in the dark tattoo. So.
I feel like it's 2020. I don't even know anymore. I've stopped questioning anything. I'm like, that's okay. This is great. Everything's fine. So let's. Oh, go ahead.
As I was going to say, we have a busy show tonight.
We do.
The feeding issues are very complicated with SDS, as Dr. Grover highlighted. So let's welcome dietitian Katherine Truscott.
Hi, good evening. I'm happy to be here tonight, and it's a pleasure being part of this great discussion tonight. I'm sorry that I was unable to meet at least some of you at Camp Sunshine this summer, but hopefully I'll answer some of your questions for nutrition.
Sounds great. And I know you do have a little bit of a presentation for us. So much like the last couple of the shows, we're going to have you share your screen. And then you can share your presentation, then we'll take some questions afterwards.
Can you see my screen?
Orva might be able to, and she might not have just put it up yet. I'm not, there it comes.
Okay.
So I'm gonna go ahead and give you the floor.
Okay. We're gonna talk about SDS and nutrition. I'm gonna do a little bit of an overview of vitamins and micronutrients, enzyme replacement therapy. I'm gonna talk about assessment and growth, diet, and dental hygiene. What do we know? Common symptoms of SDS are poor growth, diarrhea, frequent infections, anemia, fatigue, and skeletal abnormalities. Your child may have some of these, one of these, or may have had some of these symptoms. What can we do? Well, we help them with pancreatic enzyme replacement therapy. We use vitamin supplementation, so the fat-soluble vitamins A, D, E, and K, due to the malabsorption, these are needed in higher amounts. We have iron, selenium, copper, and zinc are micronutrients that we're concerned about. Concerned about dental and brushing their teeth and dental visits and an adequate diet to provide adequate calories. When we talk about the fat-soluble vitamins, vitamin A, symptoms of deficiency are dry eyes, skin, growth impairment, insomnia, immune impairment, and fatigue. And as you can see to the right, I've given you some pictures of foods that have vitamin A in them. Vitamin D, symptoms of deficiency are rickets, osteomalacia, fatigue. Vitamin D does help absorb calcium, wound healing, and dental cavities. As you can see, fatty fish, dairy foods, eggs, those are good sources of vitamin D. Vitamin E, symptoms of deficiency are anemia, muscle weakness, and visual disturbances. Nuts and seeds and oils, whole grains. Vitamin K is the last of the fat-soluble vitamins, and systems of deficiency are impaired clotting. Vitamin K sources are dark green leafy vegetables, cauliflower, spinach, as well as fortified cereals. When we look at the minerals, copper, selenium, zinc, and iron, they all have a lot of the same things: muscle weakness, anemia, poor growth, formation. Iron's important in the formation of red blood cells. And if you look below, they also all have some of the same food sources as providing those micronutrients: nuts and seeds, lean meats, dairy, nuts and seeds, tofu. So as you can see, a lot of these foods are really healthy foods, but your child may not want to always eat these. We know that with the malabsorption, there's an increased need for the fat-soluble vitamins. We know that there are specific vitamins that are designed to meet these unique needs. There are vitamins that have water-miscible form of the fat-soluble A, D, and K. They also provide zinc, iron, B vitamins. They don't have calcium. They come in liquid, chewable, and soft gels. And sometimes we do use a regular multivitamin in a larger amount, especially if insurance won't cover the specialized vitamins, because they can be very expensive. And here are some pictures of some of the vitamins that we use. When we talk about pancreatic enzyme replacement therapy, we need, it's important to take it as it's prescribed before meals and snacks. We don't skip doses, and we don't double up if we miss a dose. We make sure they're stored and dated appropriately. And we know that these levels need to be increased, especially as your child grows. So the symptoms that they may need a higher dose of the enzyme replacement therapy is they may have abdominal pain, may have increased diarrhea, they may have steatorrhea, which is the oily stools. So we're always assessing the need to increase the amount to prevent malabsorption. When we talk about infants, we use the coated capsules and break them open and pour the little beads into baby applesauce or pears into a small 1 or 2 mouthfuls. We want to make sure there are no beads left in the baby's mouth, because they can make sores inside the mouth. And then we offer the breast or bottle right after. When we look at pancreatic enzymes, so lipase units that are listed here. And as you can see, the different companies make different amounts, and we choose the pill or the enzyme that you need that best fits for your child's needs. We start off usually infants around 2,000 to 4,000 units for each 120 milliliters of breast milk or formula. For under 4 years, we may use 1,000 units per kilo per meal. And over 4, we may start at 500 units per kilo per meal. Snacks, it sort of depends on the size of the snack and what food. The question I always get is, do I have to give enzymes to my child every time they eat? And the importance of the enzymes is that they help digest the carbohydrate, protein, and fat. So if you're giving your child a snack of cheese and crackers and fruit, yes, they do need the enzymes. There are some simple carbohydrates like candy, gummies, fruit, juices that don't necessarily need the enzymes, but we don't encourage those being used often as snacks, just so your child doesn't have to take the enzymes. When we look at growth assessment, we traditionally have used 2 growth chart for 0 to 2 years. We use the CDC for 2 to 18 years. And the new SDS, we are now using, and we plot the child on that, although there definitely needs to be more studies done with this, but that's for 0 to 8 years. We're looking at the growth velocity of the rate of the child, which is the rate of the child growing. When you look at the growth velocity of a child, each month from 0 to 1 years old is a different rate. For the CDC, or over 1 year, the velocity is different for each year. And when we look at the SDS growth charts, they don't expect the children to grow at the same rate. And if you traditionally only plot the children from SDS on the other charts, they sometimes fall below the 3rd percentile. Growth failure is when a child demonstrates the inability for physical growth or unable to maintain the rate of growth over a certain amount of time. It's when your child may be at the same weight for several months, and especially in the first year of life. Or we do know that when we start using the enzymes, the child is able to grow at a normal rate. The importance of measurements are the consistency. We want to use the same scale. We like to have it about the same time of day, and we usually like to have them wearing just underwear or a dry diaper so that we have very consistent measurements, because in young children especially, that can make a big difference. These are the two growth charts. The one on the left is boys and the one on the right is girls, and they're birth to 24 or birth to 36. And as you can see, they are not the only ones that we use now. We're using the SDS too. The SDS charts definitely need some more research, but it does show us that these children do grow at a slower rate, although once they're on the PERT enzymes in adequate amounts, they can grow up to the normal rate. So how do we get these kids to eat what we need them to eat, and to eat get the number of calories that they need? We know that providing 3 meals and maybe 2 to 3 snacks is important for young children. And we know that we need to give them a break in between each meal of at least like maybe 2 hours or so that they have time to come to the next meal hungry. We often want to give children like a cookie or juice or milk or whatever in between, because we think, oh, that will help them gain weight. But in reality, we found that when you give the child nothing to eat and they come to the next meal hungry, and you're offering them what you want them to eat, they are more likely to eat it. So we recommend that meals last no more than 30 minutes. Snacks are 15 to 20 minutes. And when they get finished with their meal or snack, they get down from the table, and then they can have water in between, but nothing else. We encourage them to sit in a high chair or a table that's appropriate for their height in a comfortable position. When I say no electronics, we mean no TVs, no screens, no videos, no phones to distract them. It's important that they learn the importance of eating. Helpful techniques are offering them a variety of foods, high calorie, and enjoying eating. The variety means that maybe you offer 3 or 4 different foods in small quantities at meals. You may offer 1 to 2 different foods at snacks. A child may eat some of one food one night and none of it the next, or none of it the next time you offer it, but the other foods that you're offering are important so that they end up eating enough at a meal. We always suggest that food is offered first and then a beverage. We don't use juice. We use milk or other high-calorie beverage that's prescribed. We look at calorie enhancements like cream cheese or peanut butter, oil, sour cream, things that make other foods higher in calories. And when we talk about textures, we know that some children don't like certain textures. So we may add peanut butter to oatmeal to make it higher in calorie. We may, if the child won't eat beans or doesn't like protein, we may puree that into a soup or sauce so that they are getting some protein. We may use different forms of food. So now there's many foods that are dehydrated vegetables that are hard and crunchy but dissolve pretty easily. So we may use those. The nutrition concerns are that a lot of times there's minimal amount of eating, they have a poor appetite, and constipation. Constipation can cause children not to eat. If they feel bloated and they're just constipated, they may not want to eat. So we always recommend that GI or the PCP is brought into is made aware of the constipation so that they can help. We offer a wide variety of foods and use the oils and fats to make them each bite count. We offer preferred foods at the end of the meal, because if we offer them in the beginning, they'll eat those and then may eat less overall. We don't offer their favorite food every day, even though we know they'd eat it, and we're tempted to give it to them because we want them to eat. If we offer it every day or more than a few times a week, we run the risk of the food dropping, of food jags, as we call it, and they drop a food that they have been eating for months. Sometimes we try mini meals, so it's a cross between a meal and a snack. And some children do better with this amount of food spread out throughout the day. We avoid sweetened beverages. We avoid grazing. And we want it to be a positive experience. So we want the child to eat with their siblings or family members so that they're not the center of attention. Because when this child is the center of attention, it can be very stressful and they may not eat as well. When they come to the clinic, we spend a lot of time doing a full nutrition history and a history of their present diet. I spend a lot of time with parents to try to figure out what the family goals are and what the family wants to change first. Because usually there's more than one thing that needs to change, but making changes is difficult. And we usually only want to change one or two things at a time. We try to meet the families where they are and ask for a lot of input from them. So how do we get the children to eat those dark green leafy vegetables? How do we get them to eat the foods that we want? By offering them those foods. And actually, if you're eating those foods and they see you or other siblings eating them, they are much more likely to eat it. We do know that it may take 10, 12, 15 times for a child to eat something, but we may offer it in different forms and different ways and at different meals. So the child will at some point start eating them, or we then, if they don't, we could try smoothies, like whole milk yogurt, bananas with peanut butter and a handful of spinach or celery or whatever it is that you want the child to eat that they're not eating. Or we may puree it into the sauces or soups, as I mentioned before. Each child is unique, and what works for one may not work for, or usually doesn't work for another. And when we look at nutrition, we want the parent to look at the whole week or the whole day, not just one meal. You can't judge a child based on one meal and think, oh, they didn't eat what I gave them today, because most of the time we all eat different amounts at different times. When we talk about dental concerns, we are concerned about their teeth. They need to brush their teeth at least twice a day. When an infant is getting new teeth, sometimes they don't want to eat because of the pain. Sometimes we recommend a frozen teething toy or even a washcloth that's wet, rolled up and put in the freezer, and giving that to them 15 minutes before a meal so that their gums tend to be more numb and they're more willing to eat. Cavities can be another obstacle when it comes to eating. Children, if they have tooth pain, they may not want to eat. It's important to have cleanings yearly and or twice a year, and visit the dentist. A lot of dentists for young children will also have your child come in even before they need to clean them, just to sit in the chair and get used to being at the dentist. I've tried to answer some of your questions, but I'm happy to answer more. And thank you very much for having me tonight.
That was very, very, very informative. We've had a nutritionist in the past work with us, mostly because my son is feeding tube fed. And it's really interesting to hear you guys echoed a lot of the same things, and I never knew we were doing it wrong. And it goes against everything we've sort of learned to do the wrong way, but now we're doing it the right way, and it's interesting. So one of the questions we had come in was, what enzymes work best for feeding tubes or that can be crushed? And I know this is a question we get very often because multiple SDS children or patients have feeding tubes, and it's very hard to get enzymes in them.
Yeah. So when we, the Relazorb is a cartridge that can be attached for feeding tubes. It's based on, each Relazorb is based on 500 milliliters of a feeding tube. The only problem with those is that you can't use a food-based formula with those Relazor cartridges. So some of the newer formulas that are made from foods, you can't use those. You can crush the enzymes and put them in, but it does become an issue when kids are on feeding tubes. And sometimes we'll do some of the pancreatic enzymes spread out throughout the feeding tube, depending on how long they're on, or if they're on we'll try to transition them to boluses so that we can give the enzymes at the same time as a bolus.
And one of the struggles we had, because we're a family with a feeding tube, is we could not get Relazorb until our son was 5. And so we had to come up with very MacGyver type methods to get enzymes in before that could happen.
Yeah, that is a problem. Probably most people can learn from you because it is very tricky, and it is a hard thing to work. And I wish that there were more enzymes that were developed that would be more appropriate for feeding tubes.
Absolutely. One thing they had us do was, so my son is fed continuously overnight. And so what they wanted us to do was to wake him up every hour to give him a Creon. And I said, that's not going to be effective for anything. So we actually switched him to daytime feeds for the couple of days that we had to have him. We were out of Relazorb, and we gave it in, I think, 1.5-hour increments, but then we stopped. It was a very complicated schedule, but working with your dietitian that your patient works with already is going to be huge into figuring out the good schedule you can make.
Right.
The next question we had come in was, at what point should a nutritionist become involved?
From the beginning. Nutrition, you know, it's hard because nutrition's important, and I think that for everybody, it's not just the SDS kids, it's for everybody. And so the younger they are, and the easier it is to change some habits or prevent them from getting into bad habits. So I believe that children should see a nutritionist, or the family should see a nutritionist early on.
Katherine, do you recommend Creon or enzymes for a very simple snack like pretzels or veggie straws that aren't accompanied by like cheese or something like that?
So a lot of times this comes up, especially when kids are in school and, you know, they're having, it's usually based on how much. Like if a child is willing to eat like a whole bag of pretzels and, you know, and a whole container of juice, and, you know, it's sort of a big quantity. Sometimes I say, you know, we need to. Most of these kids don't eat the big quantity, and I feel like if they're not having pain and they don't have symptoms, that it's okay to, you know, not use the Creon during a simple snack.
Got it. Thank you.
That kind of segues into the next question we had, which was, how does eating like this work for kids that are in school where they cannot control meals?
So what we hope is that by the time the kids are in school, they've been exposed to this type of eating, and they are eating, you know, their meals and snacks, and what the family is providing or sending into school, or what the school is providing is, we know the children get too preoccupied with talking to their friends and playing around and not really wanting to eat. So we really just try to encourage the parents to talk to the kids and remind them that they need to eat and they need to take their enzymes at school. And usually a nurse is involved in that. And usually the nurses or the proctors of the meals are usually pretty good about reminding kids to eat before they talk too much.
Nicole, I've really enjoyed watching over the last week. I know Roman recently started going to school, and I've loved watching your videos that you make of the lunches you make, Roman, because I aspire to be that mom on that level, even though my kids don't go to public school. But like you cut them into cute shapes. I don't even
I'm
know
pulling
what
out
that
all
like
the
tiny
stops.
fork spoon thing was. Like that's not even a utensil I've ever seen before. It's like a toothpick with legs.
I should link all my cute little stuff. So, Katherine, my son has SDS and he has a ton of very severe food allergies. And he has never been on a feeding tube, but it's been mentioned several times. But we've been spoon feeding him most of his life, spoon feeding him. All dietitians basically said he's got way too much going on. We really don't have anything to add. But he started one of our biggest reasons to put him in school, even during a time like this, was he's never been eligible for group feeding therapy because of all the food allergies. So with COVID and everyone spread out and everything, it was finally time someone pulling out all the stops. Like this tomorrow, I should post it to Facebook. He has sight words. He's in kindergarten, so he has sight words every week. So I'm cutting his food into sight words.
Oh, that's perfect.
It's super ridiculous.
No,
His
I
teacher's
love
like,
it.
"Can you make me a bento box too?" Like it's so
Yeah,
one.
the bento boxes are great for kids.
Yeah.
Like this, because you can
So many things. Yeah.
compartmentalize a whole lot of different little things, and like they're not going to eat all of any one of them, but if they eat some of every,
But he can just pick what he wants. Right.
It's great.
Something we found for mealtime at home, my sister actually introduced it to us. She's an OT, and so naturally she has all these weird OT tools in her backpack all the time. And it's a little construction plate. I wish I would have grabbed it thinking about it instead of the hot dog
we have
costume.
that.
And it's got a little fork and it looks like a bulldozer, and then a pusher, or maybe the pusher is the bulldozer, and it goes up and on. And
we have that one.
That was so
we have
cool.
one that's like a game. It's like a game. You go around and then he wins the prize at the end.
Yeah. There's
maybe what we should. Oh, go ahead, Katherine. Sorry.
No, I was going to say there's so many unique things like that, and depending what your child likes, there's something that will go. There's sharks that will like spoons and things like that, and it just makes it more enjoyable for the child, and that's the goal, is to find what will work for your child. And that's what I said, each child is individual, and we try to find the things that work best for that child.
My kids also really love eating weird, we call it. So we'll eat normal things that we would not eat with a toothpick. We have these really cool plastic chopsticks we'll eat with, and it's kind of this it's funky and it's new, and they can't get over it. But it's very interesting. There's a lot of different ways to get food into our kids safely, and I know it's a struggle for a lot of us.
Yes.
So I think we are ready to jump into, because I don't see any more questions. So we're ready to jump into our next doctor. Thank you for being with us tonight, Katherine. I know
thank you so much, Katherine.
To a lot of families.
Well, thank you for having me.
Of course. Our next guest doctor is Dr. Wehrman. Welcome, Dr. Wehrman, to the show. Hello, welcome.
Hi. Thanks for having me.
Would you mind telling the audience a little bit about yourself?
Sure. My name's Andrew Wehrman. I'm one of the hepatologists or liver doctors at Boston Children's, and I work with Dr. Grover, who I know gave you a talk last week. And I just see now that I'm having some difficulty sharing my screen for some reason.
We'll get you through it. Don't worry.
It's 2020. It's fine. What are we going to do when it's 2021 and things are still wrong? Are we just going to keep going with that? It's still 2020.
This is still 2020.
Left over 2020.
It's one long year.
Forever. I don't know entirely where. Oh, Dr. Wehrman said that he's going to log into the different browser and see what works. So we'll see if that works. Nicole, like I said, I know you and I have a whole lot of GI stuff between us. Roman has a lot of food allergies. We have more of the feeding intolerance, the slow motility. But I don't think, and you can correct me if I'm wrong, I know Roman's had some wonky liver levels, but I don't think it's one of his big things.
He's had really wonky liver levels where even his GI who sees, I think 15, I'm sorry, his hepatologist who sees 15 other SDS patients and consulted with a lot was concerned. But like a lot of the other patients, they evened out and they're pretty close to normal levels right now. Yeah, but it was scary. He does
Oh.
have fatty liver and scarring and all that.
Do they think that the fatty liver and the scarring is necessarily from the wonky levels, or are they not necessarily connected? We
Oh,
don't
I
do
don't
a
know.
lot of
That'd be
liver
a good
things.
question for Dr. Wehrman. I'm not sure what that's from.
All right, I'm back. Can you hear me?
Heyo.
How are we doing?
Okay, great.
All right.
Can you guys
so
see the
let's
slides
have-
too?
We could until they came back down, and so I'm assuming when you're ready to go, we will throw them up with your face.
Oh. Yep, I'm ready to go.
All right.
Can you just let me know when they're up?
They're up. The
Oh,
floor
great.
is yours.
Okay, great. So sorry about that interruption. Like I said, my name is Andrew Wehrman. I'm one of the hepatologists at Boston Children's Hospital. And this is part 2 of the GI manifestations of SDS. And I know this is kind of a continuation of Dr. Grover's talk from last week. I'm really going to talk about the liver disease in SDS, as well as just some basic liver information. So I actually stole this slide from Dr. Grover, but just to remind everyone that SDS is really a multi-system disease, so it really takes a multidisciplinary approach to treat it effectively, and this is with all the subspecialists involved, including GI and hepatologists. But as physicians, we understand that our part is only a small part of your lives, and there's a lot of other extra things going on, including school, family, physical therapy, early intervention, all of these other things that go into taking care of your child. All right, so we'll just start with basics about the liver. So the liver is an organ, and it's in the right side of your abdomen. It's actually a very large organ, and you can see on the picture on the left, it's very close to your intestines and your pancreas and your stomach. There's a variety of connections to the liver. There's actually blood vessels that go from your intestines to your liver. And then there's blood vessels that go from your liver to your heart. And then your liver also has small tubes in it called bile ducts. These transport bile, which is made in the liver, into your intestines. And we'll talk about that a little bit on the next slide. And then part of the bile duct system is a sac called the gallbladder, which also stores bile. All right, so a lot of people ask me or don't really know, what does the liver actually do? And the answer is it actually does a lot of things. One of the functions of the liver is to make bile, and bile is a substance, it's a liquid that's made in the liver cells and then transported into the intestines through those connections called the bile ducts, those tubes. And bile is really important for digestion and absorption of different fats and vitamins and food. The liver also makes a lot of other things. It makes proteins, and these proteins are important for normal clotting function in the blood, and many, many, many other proteins. It makes a lot of different things. And then it takes the nutrients from your gut and helps metabolize it so that your body can use that energy effectively. So like I said, there's blood vessel that goes from your intestines to your liver. So when your intestines digest different foods, it goes into that blood vessel and that makes its way to the liver, where the liver can process that. So a lot of very important functions in the body. So how do we assess liver and how the liver function is and the liver, how the liver is? The first step is an examination. So the way that we examine is on the right side of this slide. You can see the rib cage and the examiner's fingers right below the rib cage. Typically, you can't feel a liver below the rib cage, or if you do, it's very small amount. So when the liver is enlarged, you can feel the liver edge go below that rib cage. You can also feel the texture of the liver too. Sometimes it feels hard. It should feel soft and silky smooth. We also examined the spleen, and the spleen is another organ inside of your abdomen. It's actually on the left side, opposite of the liver. And the spleen can sometimes be enlarged due to liver disease. but there's also a variety of other reasons that can make a spleen enlarge, including some blood disorders. So that's another thing that we'll examine when we're assessing the liver. And then we look at the skin very closely, and we're looking for yellowing of the skin. This is called jaundice, or yellowing of the eyes, which is called scleral icterus. And you can see the yellow eyes in the picture on the right. This would indicate elevated bilirubin in a person. Be very, very atypical for somebody with SDS to have jaundice, but is part of our normal exam of the liver. So how the next step is really labs, and liver doctors, we really like labs, and we get labs a lot. And I'm sure your doctors may have even rattled off some of the different lab values that we get. So I'm hoping to explain some of those a little bit to you. The first set of labs that we get is something called liver enzymes. These are called ALT and AST, if you've heard that. These tell us when there's injury going on in the liver, and they go up when there's inflammation or irritation going on in the liver cells. There's also other liver enzymes called alkaline phosphatase, or GGT, and that tells us if there's damage or irritation going on in the bile duct cells. So there's two types of cells in the liver cells and the bile duct cells. The liver cells, ALT and AST, and then the bile duct cells, GGT and alkaline phosphatase. The ALT, AST, alkaline phosphatase, and GGT doesn't really tell us if the liver's functioning. It just tells us if there's irritation going on in the liver or inflammation going on in the liver. The tests that actually tell us how the liver is functioning and doing its job are listed here. One of them, the important one, is called an INR. That's how well your blood is clotting and telling us that your liver is making those proteins that it needs to. The bilirubin, if your bilirubin goes up, that tells us that the liver might not be doing a good job at getting the bile from the liver into the intestines. And then albumin, which is another one of your body's proteins that the liver makes. And in end-stage liver disease, this would be low. And then we also really monitor vitamin levels. So Katherine already talked to you about the importance of vitamins A, D, E, and K. These vitamins require bile for absorption and require good liver function for absorption. So we do monitor these as well. And somebody with SDS who has low vitamin levels, it's probably not related to the liver disease and more related to pancreatic disease, but still important part of our evaluation. The next step is imaging studies, and we have a variety of modalities to really look at the structure of the liver. I would say the most common one is an ultrasound. There's a representative image of an ultrasound in the upper right-hand corner. Everybody's probably heard of an ultrasound, but it's a probe on the outside of the skin, similar to when you're pregnant, looking at the baby. These tests are very cheap. They're very easy. There's no radiation, and they're very, very good at looking at the liver. We can look at the actual liver tissue and see if it looks normal. We can also estimate the liver size, and it's very good at looking at bile ducts as well as blood vessels. So it's usually our first step in evaluating the liver. And then more recently, we have tests that's looking for scarring in the liver. The ultrasound unfortunately doesn't tell us much about scarring in the liver, and we'll talk about why that's important in the following slides. But we do have some other tests that help us estimate how much scar tissue is in the liver. The one that we use at Boston Children's is called a FibroScan. This is similar to an ultrasound. It's in the bottom right-hand corner where the probe is placed on the skin, and it actually vibrates and helps estimate if there's any scarring in the liver. There are other ways that we can do this. This is just the one that we use at Boston Children's, but there's others called shear wave elastography, as well as MRI, that can also estimate the amount of scarring in the liver. And then ultimately, sometimes we need to do something called a liver biopsy to really understand what's going on in the liver. This is a procedure that's often done by either a hepatologist or a radiologist. The patient is usually under at least some sedation or anesthesia. If it's a child, sometimes they have to use anesthesia. Whoever's doing the procedure cleans the skin off on the right-hand side of the body in between the rib cages and introduces a needle into the liver and removes a piece of the tissue. And then we can make slides of that tissue and look at it under the microscope and look at how the liver looks under the microscope. And specifically, we're looking for inflammation, scar tissue, any problems with the bile ducts. We can look at the blood vessels. It gives us a lot of information when we need it. So putting this all together, why is this so important? And the main thing is what we're trying to avoid is severe liver disease. So we think, and in most cases, liver inflammation or irritation in the liver can sometimes progress to liver scarring, also known as fibrosis. And when that fibrosis or scarring continues, it can turn into liver cirrhosis, which is the end stage liver disease. Not everybody who has liver inflammation goes on to this fibrosis or cirrhosis. Liver cirrhosis can really lead to a lot of different complications. I listed a couple of them here, but it's pretty significant. Unfortunately, sometimes fibrosis can occur even without inflammation. So understanding the liver stiffness and estimating the fibrosis is really important for us to know. And also important to know is that symptoms are pretty rare in early liver disease. So it's really important to get some of these screening tests to really rule out any significant liver disease, because sometimes it can be asymptomatic. And the main reason why I'm here is that we need to monitor the liver to look for fibrosis, ensure that's not progressing. And I don't put this slide up to scare people, because the vast majority of people do not progress to cirrhosis or end-stage liver disease. And in SDS, that actually seems pretty rare, which I'll talk about here. So what do we know about the liver disease in SDS? And I'm sad to say we don't know much, unfortunately. There's very little literature that really definitively shows the liver manifestations of SDS. This article that I put on the slide is probably the largest one that I could find, but it only included 12 patients. This was done in Finland, and the patients were both pediatric and adult. The ages were 2 to 37. This was a retrospective chart review, so they identified these patients and looked back through their chart over many, many years, looking at their liver labs, looking at their clinical notes, and then they also did some additional imaging studies and labs at the time of the study. Their overall findings were that liver disease seems to be mild in the majority of the cases. The liver size could be large in younger children, but this seemed to be normalized after a couple of years. Same with the liver enzymes. So those lab values I talked about a few slides before, the ALT and the AST, seem to be the highest in young children, and it gets better with age. And then the one interesting point that they found is that there's mild cholestasis. That just means that there's abnormal bile flow was seen in some adults, but this was really of unknown significance, and none of the adults in this study really had significant liver disease, so we don't really know how important this is. With that said, there are several case reports of more severe liver disease in people with SDS. I just put a couple of them here, but there's one report of cirrhosis in SDS in a child who needed to have a liver transplant. There's one case report of more inflammatory condition called autoimmune hepatitis that happened in a child with SDS. And then there's one patient who needed to have a liver transplant for chronic liver disease that was more related to vitamin toxicity, not necessarily related to the Wehrman diamond, although it could have contributed as well. So I think from the literature that we have, the vast majority of kids' livers are not affected and get better, but there are these rare case reports reported. So how do we put this all together? Like I said, liver disease is a known manifestation of SDS, but it's really not well characterized. Seems like children can have elevated liver enzymes and a large liver that seems to get better with age, although there are reports of scarring and impaired bile flow. The liver disease does seem mild and seems to improve with age. And like I said, there's some rare case reports of more significant liver disease. So what are we trying to do? Well, with Dr. Grover and the SDS clinic, we're trying to standardize our approach to evaluation of children with SDS. And part of that standardization is really to get routine liver labs to make sure that we're not missing any liver disease. And if there is liver disease, an evaluation by a gastroenterologist or a hepatologist would be prudent. And then, at least at our center, we're doing FibroScans, which is that test to look for fibrosis, at least semi-routinely, because we do know that there can be fibrosis without significant lab abnormalities. There's no evidence to support any of this because we don't really have much literature, but I do think that it might be reasonable to follow these kids, at least early on, pretty closely to make sure that the liver disease isn't progressing to something more significant. All right, and with that, I just have any questions. I think
That was
you're
a very
muted.
good presentation. We are not, am I still muted?
Nope, you're good.
I'm good? Okay.
Yeah.
I know so we're not a family that's followed by a hepatologist routinely. We have never had to be. We do, our hematologist puts in liver labs every 6 months when we do regular labs just to have them done. And our GI keeps kind of a close eye on it because we know it can become an issue. But so this was very informative for me. I found myself taking notes because I didn't really know any of this. I've never had to. So
Is that common with clinical patients, Michelle, that the liver isn't as severe?
I mean, I'm not a researcher, but in all the clinical families I've seen, I know that we tend to have a lot more of the
Lung.
weirder organ issues. So,
Mhm.
you know, the lung or more of the slow motility, you know, they're not, you know, totally off the wall, but they're not, you know, the liver, we still have pancreas issues, but so yes, no, I don't know. I don't know. You know who does know? The SDS registry, and you should join it because then other people would know.
Dr. Wehrman,
I
do
don't
you
think
see
that's
that
far
with the
off.
clinical patients, that
I'm
their
sorry.
livers aren't as severe?
Yeah, so I think we are noticing that it seems to be pretty mild when the liver is affected. But I think we just really don't have enough information to really know the extent. I think if the liver disease was more significant or causing problems in more patients, we'd probably have more reports of it. The reports still seem to be pretty rare.
A couple of questions rolled in, and we had to transplant it because we're having some video issues. But one of the questions was how important is liver imaging for SDS patients? And then you kind of answered it, but maybe could we reiterate when should they start getting liver imaging and or liver labs?
Well, I think definitely at diagnosis, getting liver labs is reasonable to see if there is any liver involvement. I think you know, you have to talk with your gastroenterologist to see what's best for your specific child, but I would routinely get at least an ultrasound at diagnosis if the liver enzymes were abnormal. And like I said, we're trying to do yearly FibroScans on our patients just to monitor for any fibrosis, with the caveat that there's no evidence that's not an evidence-based decision that we're doing. It's just that it seems reasonable to me.
Yes. Another one of the questions that came through is actually it was Nicole and I kind of talking while you were switching browsers over. Would a fatty liver or scarring on the liver be a product of those high levels?
So the fat in the liver can cause elevated liver enzyme levels. And we do know from the rare reports of children with SDS who have been biopsied, there are some that have fat in them. So that could definitely be contributing to that. I think we don't really know what contributes to the scarring that's seen in those case reports of children with SDS, whether that's inflammation or not related to inflammation at all. Unfortunately, I think we don't have enough information to say definitively. But I think if you have high liver enzymes early on that get normal, that's reassuring that your liver disease is probably not going to progress. Does that answer your question?
So I also believe, kind of, I don't know. We also, Katherine wanted to come back and help answer questions too. She's not on video, but she is here with us. And then this seems to be somewhat of a common occurrence with not just SDS, but children with rare diseases who may sort of fall through the cracks or don't have a lot of articles written about them. What if there's high enzymes, but the GI will not address it? We find this as a clinical family. Our voice being heard is really hard sometimes until you find the right doctors that listen. What are there any type of articles out there that these families could bring to their doctors to really express, no, this does need to be monitored?
I think the articles that are in my slides, which will they be, I guess you could find them for sure, are probably the biggest case series that are reported. But it's probably just a lack of understanding the extent of liver disease in SDS. And some people do have elevated liver enzymes for many, many years, and it doesn't cause them any problems too. So probably the papers that are in this presentation would be good to present if you're getting some resistance or if you wanted them to know a little bit more about the liver manifestations.
And we'll make those available as well as putting the slides up in an album so people could read through or share them, or and then having the links accessible so people can print them and send them to doctors or bring them to doctors. Or I think that's been one of the best things about doing camp virtually is that we're trying to make it really accessible to everyone who would need it versus the people who would get to Maine. And
Yep.
It's kind of been one
That's
bonus
my
of
favorite part.
2020.
Yep.
That's all the questions we have from viewers. Nicole, I don't know, did you have any that were kind of tucked away or that were submitted
No,
to
we
you
did
or
great
anything?
on time considering we had 2 guests tonight. Wow, look at us. We're kind of getting good at this,
We
Michelle.
did. We're almost on top of things. Watch out.
Thank you to
I
our
don't know about that.
guests.
Maybe we're getting better.
We're getting better. Thank you to Katherine and Dr. Wehrman. You guys were fantastic. Again, this camp series is so awesome because it is accessible to everyone that wouldn't be able to go to camp otherwise.
Thank you for having us.
Yes.
Did we have any other questions? Michelle, did you see any
No,
other
I don't
questions?
believe so. I was just gonna throw in a shameless plug that if you're not on the SDS registry, being on the SDS registry is a huge the stepping stone into getting these research articles done, having doctors understand more. The more people that are on registries that are able to be, I don't want to say monitored, like closely monitored, but the more people that know about all the SDS patients, the more research can be done and the more that a cure can be found.
It's just too rare.
therapy.
Every patient counts, literally counts. And
Yes.
Each patient may manifest differently. Their symptoms may manifest differently, and patients are getting older and living longer. So just the registry is so important. So we'll link below how to get on the registry. And a reminder of our giveaway. Like, comment, share, start a watch party, interact with the show in any way, and you could win the liver plushie, which is super
He's
helpful.
so cute.
He's so
I
cute.
actually
We have
the
one.
liver plushie, and
My
it's
son
very
brings
nice.
it to his liver appointments.
Is there a gallbladder plushie that
There
attaches?
is. There is. Dr. Wehrman, do you have this liver plushie?
I have the liver. It's very nice. Yeah.
We're gonna need to give away a whole body set, and then we'll have everyone take a picture with it, and we'll kind of put them in a collage like a body.
There's even erasers. I mean, who doesn't need a liver eraser? It's so smart.
I need a lot of them.
Okay, guys. Everyone stay safe. We have upcoming shows we're booking now. So we'll be promoting those soon. Thank you, everybody. Thank you, Michelle.
Yes,
Thank you, Orva. Thank you, everyone behind
Wash
the
your
scenes for the show.
Thank you for having
Wash your
me.
hands. Bye.
Yes, have a good night, everybody.
Bye.